Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with ear infections in both ears, but what was obscuring the view of the ear infections was, this is the patient's left ear, and this ear had a combination of earwax and discharge and debris due to the ear infection. And we can see here, I'm just using a fine end suction probe actually because the ear is quite swollen, it's inflamed, there's not much space in there. And I'm just using the fine end suction probe to just suction out this wet debris. You can see it's really slushy almost in consistency. And it's really impacted, it's really deep in the ear, this is. And I think that was the occlusion removed. It's all this wet debris around the edge, so I'm going to mop that up. There's a lot of dead skin as well coating the medial part of the ear canal. So when we say medial, we mean closer to the eardrum and further away from us, the clinician. As you can see, there's dead skin that's on the posterior canal wall, so the back part. So I've just about managed to insert the endoscope into the ear, but it's just got a bit blurry because of the infection. There's a bit of dampness around the ear, so I just wiped the lens and I've just gone back in. And that's the patient's eardrum, believe it or not. Now, obviously it doesn't look like a normal eardrum. There's a bit of discharge at the bottom. I am going to just mop that up. So the patient has got multiple perforations of the eardrum and the eardrum's inflamed. It's a condition called myongitis. And we just can't recognise any of the landmarks of the eardrum due to this infection and all the discharge. So myongitis is an inflammation, an infection of the eardrum itself, so that's the term given. You could also categorise the infection as something called a suppurative otitis media, so that's when you've got a middle ear infection, which this patient does have, because it's very likely all this discharge that I've cleaned out, it's actually originating from the middle ear as opposed to the ear canal itself. So when you have an ear infection of the outer ear, so the outer ear consists of the cartilage that's visible externally, so the satellite dish, so that forms part of the outer ear, the ear canal itself, and the outer membrane of the eardrum. So the eardrum has three membranes. The outermost membrane, if that's infected, that region we categorise as the outer ear. And if you've got an ear infection of the outer ear, we call that otitis externa. So oto is Latin, I believe, for ear. Itis is a medical term given for infection. So ear infection, and then externa is the external part. But I think all this discharge is actually not due to otitis externa. It may also be a combination, but more likely it's all this discharge is coming from behind the eardrum in the middle ear. So we call that otitis media. You get different types of otitis media. You can get acute otitis media, which if you keep watching, actually, ironically, the patient has that in their right ear. Acute otitis externa is when everything's really inflamed and red and the eardrum's bulging. You can get secretory otitis media. That's when you've got middle ear fluid behind the eardrum, and that fluid's more yellow in appearance. And you can get suppurative. I may have not, my pronunciation is not very good, I do apologise, something that I do struggle with. So that is the infection of the middle ear, and that discharge in the middle ear can weep out. As you can see there, the discharge has already formed again, so I'm just going to go back in. It is such a narrow ear canal. Now, because it is narrow, it's actually inflamed, so I would actually say the patient has got both otitis media and otitis externa. And I'm just delicately just positioning the fine end suction probe. You can see when I removed that discharge, it revealed one of the holes in the eardrum. There's still some debris, so I will clear up as much as possible. And if you stay tuned, the right ear, in fact, is actually a lot more narrower. There was a lot more traditional, should I say, earwax in that ear. And as I mentioned a moment ago, they have got a very acute otitis media. So this patient's been referred to their GP for some medication. Now, in this ear, they can't have your typical antibiotic ear drops. So you can get oral antibiotics, so we take that through our mouth. You can get topical, so we introduce that through the ear canal. The more common antibiotic ear drops are what we call ototoxic. So ototoxic means that if these antibiotic ear drops enter through the eardrum through to the inner ear, with the organ of hearing as the cochlea, it can cause permanent damage to the organ of hearing. That's what the phrase ototoxic means. So ototoxic are a group of medications that can cause permanent damage to the organ of hearing, the cochlea, if it comes in contact. They're typically a group of medications called aminoglycosides, and aminoglycosides end in the word mycin, so either ends in MYCIN or MICIN. I'll give you some examples: neomycin, streptomycin, erythromycin, gentamicin. There's a few more, I'm sure, but they're just a few examples of ototoxic aminoglycosides. So for this particular patient, they can't have that, so they can be prescribed. Again, my pronunciation of medications is really not great. I need to improve it, and that's partly because we don't prescribe them ourselves, but as audiologists in the UK, we're not prescribers of medication. Let's say ciprofloxacin. They are typically, there's two types, I believe. They're normally prescribed for the eye, but more recently they have developed a version which is before they were developed for the ear. I'm aware that doctors in ENT would sometimes prescribe that off-label for use in the ear, but the manufacturers have now developed specific ear drops for that, and they are non-ototoxic, so the patient would benefit from that. They probably would be prescribed some oral antibiotics as well. So we've written to the doctor, and they've been hopefully referred to ENT as well. This video, I was just looking through my archive, I've got so many, and it just came up, so I'm hoping I've not published this before. I don't think I have, because if I have, I wouldn't have had the raw copy, but this stems back from January. So I've got so many videos to get through, guys, and I'm trying my best uploading as regularly as possible. The memory is running out on my... So this is stored on the iClearScope. The iClearScope is the wireless endoscope that we've developed at Clearwax, and we use an iPod Touch 7th generation. The reason for the iPod, it's light, it's a separate device, but the memory's not as much. You can get different memories on them, but it's more commercially, because we obviously manufacture and distribute the device. The camera on the iPod 7 is more than suffice enough for earwax removal. And it's just commercially more affordable for our delegates who purchase it. It's more than adequate, but the memory is a bit smaller, and I've got so much there. So this is the right ear, and this is the acute otitis media. You can see the back part of the eardrum and the central part, the pars tensor, part of the pars tensor, which is the main body of the eardrum, that's really acutely inflamed. There's hematoma there. It's very likely to be glue ear fluid behind the eardrum. So, and that was not visible, and the patient didn't come in reporting any symptoms with their right ear. It's purely their left. Sometimes that happens when you've got an ear infection of both ears, or just even with simple earwax. If you've got an earwax infection of both ears, if one's worse in the ear, the patients typically just notice the worst ear. They think the better ear is actually absolutely normal, because they're using their bad ear as a reference point. And it's only once you've cleaned the worst ear and the patients then think, oh, I can't also hear from my bad ear. You can just have a perspective there how narrow this entrance is. So, not entrance, this is mid-canal where I'm going through it. So narrow. That's a good view there. So again, I'm just mopping up. So the patient has been referred to their GP so they can be prescribed the correct medication. I've also suggested an onwards referral to ENT, in particularly, not only because they're right, because this is quite acutely inflamed. You can see it's bulging out, but also due to their left ear, that definitely needs to be assessed by ENT. Well, I hope you enjoyed that video, guys, and you're all keeping well and safe. Remember, be nice and be kind to each other. Take care. Bye.